everybody. It is May 9th, 2025. It's about 10 after 11. We're a little bit late on our start this morning. It's been a busy week here at the HCMA, and I'm sure up at Leahy with Dr. Marty Maron, my sidekick today. Good morning, Marty.
Just today? I'm your sidekick? What do you mean?
My sidekick more than that. We've been doing this a long time.
For 25 years. What are you today?
Well, yes, on podcasts. And, when you say things like 25 years we've been doing work together, it just makes me feel old. So let's narrow down that.
Well, we are.
Yesterday I was at a conference and one of the speakers got up, real slick guy giving a great talk. And he's referring to AI technology, and he talks about things that were around before he was born, in the 70s and even in the 60s. And as a child of 1968, I have to say a little part of my soul died. So 60s wasn't that long ago. Please tell me it wasn't that long. But hey, there we are. So this is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. It is Medical Management May. I'm here with my co-host today, Dr. Marty Maron of Leahy Clinic, and we're going to enter into a conversation about what's going on with medical management and HCM. We're going to touch on such topics as some upcoming trials, some information that's been recently updated from our friends at Cytokinetics, and we're also going to talk about some general questions in the community about medical management of hypertrophic cardiomyopathy. But before I get started on a really engaging conversation, I wanted to give some updates from the community because I am trying to include that in our weekly podcast. And Marty, I think you're going to find some of these really inspiring. So 2 weeks ago today, we went down to Orlando, Florida for an in-person patient meeting, which was last Saturday, and had 100 people come out. Great meeting. It's fantastic. Thanks to all the people at Advent for that. But the night before the meeting, Stacy and I went over to Advent Hospital to visit one of our longtime clients, Brian Wolski, who was awaiting a heart transplant and had been on the list for 371 days. And when we went into the room, Marty, you know the look of somebody who really needs that heart. His color wasn't good. His eyes were not his.
Right.
And it was time. This guy needed his heart. And I gave him a big old hug when I left. And I asked the universe to send all the positive energy and get him that heart. And we had our meeting the next day. And Sunday morning, I woke up to a text message saying a donor had been identified. And on Tuesday, he had his transplant. And on Thursday and Friday, there were some really bumpy roads and some challenges. And on Saturday, he woke up. And last night or the day before, he was moved back to the floor. He's out of ICU and he's doing well. 371 days on the list, a long wait for this amazing gift from a donor family. So props to Cassie and Brian, Cassie's his wife, who've been real troopers through this entire journey. And now they're on the other side to transplant. So we wish him well. And I hope he's listening this morning. Then one of our clients of almost 30 years, one of our first young lady, when I met her, she was 8 years old. She's gone on to have 2 different heart transplants so far. And the second transplant is failing due to vasculopathy. And Esther was in need of raising funds to get an out-of-state transplant. The community stepped up. Her individual community and the greater HCM community raised $40,000 in a week to get her on that list for her second transplant. She was approved. She's status 1A at Vanderbilt right now on ECMO, waiting for her third heart. Please keep those positive thoughts coming to her. And if that's not enough, one of our dear friends with our friends in Toronto got the call for a heart this week and notified from his sister yesterday that his transplant went well. So we have 2 down, 1 to go in some really dramatic moments here at the HCMA.
Wow.
What's amazing to me about 3 of our community members transplanting or needing this within about a week to 2 weeks, we are so much better at optimizing care and timing them to transplant. Marty, when you and I started this work, those patients probably all would have died in this week, not gone to transplant, or they would have died soon. Right. We weren't doing a good job getting those non-obstructed in the process to transplant. And thanks to you, You helped us write the guidelines for UNOS for HCM transplant back in 2018, and that made it easier for our people to get on that list. And we're seeing the right people get to the list at the right time. And I take these moments to kind of show the ecosystem of something that you and I talked about in 2016, 17. It was finalized in 2018. It changed practice. And now in 2025, patients are benefiting from these guidelines and they're getting to transplant on time. So yay to all our transplant friends. So How you like that for a week?
Love it. Love it. Unbelievable. Let's keep our fingers crossed for everybody there.
Yeah. And to their care teams, you know, you're invested in it too. You were there for the ride for some of these patients who get that far. And it's nice to see those success stories for all of us. It reminds us why we do the work that we do. So we have a note to you here, Marty. Laura sending this. Love and prayers to Marty and Leahy team. Always praying for you. That's nice. So appreciative of Ethan, Dr. Silver, Ashley, Susan, and her husband's second ICD was implanted, or it will be implanted on May 29th.
Yep.
So a little love being sent up to Leahy too.
All right. Thank you, Laura. I appreciate that as always.
We love that.
Send the love back. Yep.
So medical management May.
Yep.
Marty, how's that toolbox looking for HCM medical management in 2025?
Well, I think it's probably, we could probably kind of do two sides of a coin right now a little bit about that. I mean, I think there's obviously enormous amount of enthusiasm and progress that's been made on increasing the options for very effective medical therapy for patients with symptomatic obstructive HCM. And of course, talking about things we've talked a lot about over the last years here, which is the myosin inhibitor drugs, mavacamten being the one that's approved right now. And that's had an enormous impact on providing many, many patients now globally, since it's been approved now in many, many countries outside the United States, and more probably coming in the coming days. The option of getting a substantial improvement in their quality of life with that drug, and to say that has had an enormous impact on the management of this disease would be an enormous understatement at this point, and so we have provided really with that new class of drugs, and aficamten is the second in class, which is still under investigation, but had a very favorable phase 3 trial that was published several months ago. And I know there's a lot of work going on with, ultimately looking for that application for a new drug application right now. And so there may be even more options for myosin inhibitor therapy in the near future here as well. So look, for obstructive HCM, it's been huge. I think maybe let's pause there for a second on the very positive there.
So I think that's a great way to start. And I think obstructive HCM has captivated everybody's attention for so long. That mechanism of obstruction is quite dramatic. It looks dramatic. It feels a bit dramatic. Obstruction is almost a disease state in itself when you talk about the physiology and you talk about the symptomology. It's easy to get success by removing something so big. If you get rid of obstruction, you're going to feel better. It's going to look better. It's really easy to measure that piece. The non-obstructed people, however, become more challenging to nuance improvement. And I think that's where we'll talk a little bit more about that later, but I love what we're doing for obstructed patients. If you're obstructed, now's the time to be obstructed. You have so many options.
Right.
And should we still do what we used to do? Should we start with the beta blocker and a calcium channel blocker? And should we step therapy patients up, or do we know enough yet to say, let's just start with a myosin inhibitor or something similar?
Yeah. So yeah, a couple comments on that. So first of all, just so those listening, kind of fully understand, I think that really important principle that you just raised is that 2/3 of patients with HCM have the obstruction, okay, that form of the disease, right? And so, it kind of, as you were alluding to, and obviously you were really right on the mark here, is that it's unique because when you obstruct blood flow from the mitral valve, the reason again is that the mitral valve is getting pulled over and it's touching the septum, the thick septum, during the ejection phase of blood out of the heart. And that impedance to flow, which is similar as an analogy to sort of if you just sort of clamp down on a garden hose and water backs up there in a finite space, with obstructive HCM, you've got blood very, very momentarily backing up, so to speak, in the left lower chamber of the heart. And that creates very high pressures, okay? And that's why patients struggle so much, is that eventually those high pressures make patients feel poorly, out of breath, tired, chest pain, feeling like your heart's pounding out of your chest. And so you're right. So that's why, it's an important point, because that's why anything that can lower or normalize that obstruction, so normalize the pressures by getting rid of the obstruction, has such a profound impact on making patients feel better. Okay. And we've been doing that, for a long time, for example, with surgery, right? With myectomy and alcohol ablation, we've been very effectively, with an invasive procedure, relieving that pressure gradient, restoring the pressures to normal. And patients over the last 60 years, for example, with surgery, got so much better. That was the enormous benefit that comes with operation. And now we've sort of translated that in a way to being able to get a similar benefit with the myosin inhibitor drug that we couldn't have got, that we didn't really get in terms of efficacy with other drugs that have been available, the beta blocker, the calcium channel blocker, and even disopyramide. So that's really been the leap here, right? It's that we've been able to sort of translate, in a way, the invasive improvement with relieving gradient to taking a pill, in a way. And that's really been the profound, I think, transformation here. And so that's what's going on. That's what's at play here. And then you raised the other question here, which is that given that benefit that we've seen with myosin inhibitors, is there the potential role for maybe using that class of drug as a replacement, in a way, for beta blockers, even initially, for example, okay? And let me say that first, that's been something that's been on the mind of many of the experts and investigators in this disease for a long time now. And in fact, we have a trial that is addressing, a clinical trial that's addressing that very question, okay? It's a clinical trial called Maple HCM. Maybe some that are listening have actually patients that have participated in that trial. That's been a phase 3 trial sponsored by Cytokinetics, looking at aficamten versus metoprolol, beta blocker, as essentially first-line therapy for symptomatic obstructive HCM, to answer that question that you just raised. And the good news is that we're going to know the answer to that question from the clinical trial in the near future here, not that far along here. I think probably in the next couple of months, we'll know the answer there from a scientific standpoint. How much, if there's a benefit, and then what that benefit looks like by actually starting aficamten, a myosin inhibitor, first versus a beta blocker first.
I'm going to ask you a question. It's a trick question. How many randomly controlled clinical trials have happened evaluating the use of metoprolol or Toprol XL in hypertrophic cardiomyopathy? How many trials?
Well, I think so to make it simple, essentially zero. We've had some observational studies looking at the effect of beta blocker on symptoms, the gradient, and exercise capacity. But what we've never had is a head-to-head comparison between a beta blocker and another treatment. Okay, that's never happened. In fact, that's never happened in this disease, comparing any two treatments, whether they're drugs or anything else, in a way. And there's a number of reasons for that, why that's not happened up to this point, but it hasn't. And so that's why, and I think you're alluding to this, we've really entered, in that way, kind of a whole different era in a way in this disease, because we've actually gotten to the point where we are actually comparing efficacy and safety between two established treatments.
Right. So we're going to get some data on that soon.
Yep.
Within the year. Yep. And
it'll probably be less than a year, I think, just to be clear, just so the listeners know, it's going to be less than a year.
I think it's Q3, I think, is what we're expecting. So we'll see.
6 months, let's say probably between 6 and 9 months.
Oh my God, it's already May. We're almost halfway through the year. How did that happen?
Yeah.
Isn't this year just start? Right. So yeah, a couple more months.
A couple of months, probably, that's an estimate, but probably. But so anyways, it's going to be definitely way less than a year.
So that's what we're learning from MAPLE. Now, there's been trials in non-obstructive HCM with myosin inhibitors that we just got some news on. And that's the Odyssey trial.
Right.
And the endpoints weren't met. So the primary endpoints. So for our listening audience, could you just remind them what a primary endpoint is and why it's important?
Yeah, primary endpoint, what that term kind of refers to is in a clinical trial where you're investigating, in this case, a drug, a new therapy, a drug therapy, an endpoint is used to assess the efficacy of that therapy compared to usually a comparative group of some sort, usually a placebo group, people on placebo. And so the endpoint is what we're judging the treatment effect with. And usually that endpoint is something obviously clinically relevant. Maybe it's an improvement in how patients feel, a measure of that. Maybe it's how they improve in their exercise capacity. In many, many other trials in cardiology that are not HCM trials, but in other diseases in cardiology, a lot of the primary endpoints are based on mortality. Does the treatment actually make patients live longer or stay out of the hospital more? But those endpoints occur so uncommonly in HCM, we don't use them as primary endpoints. We use endpoints that are reflecting the most important thing to patients, really, is how they feel and how they function. And that was the case with Odyssey, the trial you just spoke about, as it has been with the other clinical trials in HCM. Endpoints that reflect change in how patients feel or function with the treatment.
The endpoints were not met.
Right.
What does it mean? How do you determine if it's met? What is the numeric calculation, and how does that make unravel the mystery for patients who are like, what do those numbers mean?
Yeah, to make it sort of, more simple than not, I mean, all that really means is that when you put together a clinical trial, you usually define upfront what the difference you need to have in terms of, let's say, for a primary endpoint of how patients feel. You predetermine how much of an improvement you need to see with the new treatment compared to the patients that are not on the treatment, that are on placebo, okay? And that difference in improvement is usually what we call a kind of a clinically meaningful difference. It's an improvement in how patients feel that most of the community would agree would be a really relevant improvement if it occurred, okay? And so when it's not met, what that means is that at the end of the trial, when you compare the improvement in symptoms between the patients that were on the treatment versus placebo, that difference or that degree of improvement wasn't met, meaning that the treatment didn't exceed that degree of improvement that was predefined. It didn't meet it, meaning it wasn't statistically significant difference between those on the treatment versus placebo, i.e., the treatment didn't work enough to be meeting the endpoint. That's how we usually look at it.
So Odyssey did not meet its two endpoints.
Right.
We don't know about the secondary endpoints yet. They still need to be investigated. And that means that some patients have been notified that their trial participation for the non-obstructed is not going to continue. But that doesn't seem to be, we don't have complete understanding on the long-term extension study participants. So we're trying to figure out exactly what this is going to mean for them, because some of these patients have been on therapy since Maverick. So for those who don't know, Maverick was the first non-obstructed study in a myosin inhibitor started by MyoKardia, then acquired by BMS. And then a lot of those long-term extension patients ended up in Odyssey as well. So there's this convergence of patients who've been on myosin inhibitors for 6-7 years with non-obstructive HCM, who objectively are reporting improvements in quality of life, but the endpoints didn't match. So now we have patients with non-obstructive HCM who were doing better, who may not have access to meds anymore. I think we need a different study design. And can you talk a little bit about what is your take on all of this?
Yeah.
Complicated.
It is complicated because, we don't have, obviously, really almost any information at this point to really get into any kind of details in terms of how to exactly look at what happened with Odyssey, and put it in sort of context at all, really. All we have is, a press release, really. We don't have anything else. That was it, where there were no data provided. It was just commentary saying that the endpoint, as you said, the primary endpoint was not met, which meant that what that meant, just so everybody's clear, is that Odyssey was a phase 3 trial looking at whether mavacamten, a myosin inhibitor, was going to improve how patients with non-obstructive HCM feel and function. Right? That was the primary endpoint, was looking at whether mavacamten was able to, over placebo, over regular treatment, improve to a degree that everybody thought would be a relevant change in how patients feel and how they exercise, their exercise capacity. That primary endpoint was not met, which meant that mavacamten did not do that. It did not provide a statistically significant, so to speak, difference in how patients felt or function compared to placebo. That's all we can conclude from what we know. Everything else would be, starting to get into speculation, which we can do, but it's speculation at this point because there's lots of different possibilities for why the primary endpoints may not have been met. And you're right, we don't know what to say either about other endpoints, what we call secondary endpoints, which may point, if, for example, those were positive, could still point to the possibility of some benefit here that may not have been fully reflective in the primary endpoint. The decision, though, I think it's important to say that the decision that you're talking about, and I think you're saying that you're hearing that patients that have been on mavacamten that are not obstructive as part of the clinical trial initiative and the what's called the open label extension, which means that patients continue to take mavacamten who were part of a phase 3 trial are being asked to stop it. Is that, and I think
we have not gotten a clear pathway yet to understand how they might maintain access because there's no label for non-obstructed, and if the trial's not going to continue, and we're waiting to get some more information. Everybody's figuring this out in live time, so no criticism here, but there are patients who are wondering how they can continue on, and some of them may not be able to, which is really sad if that's the way this turns.
Yeah, I mean, absolutely. We're not, I think we're just trying to understand what's going on here. I think we don't know yet. I think we have to wait and see, of course, how things are going to play out there. I just thought I'd heard you say that some people have been asked to stop taking the drug.
Some people have been advised that the trial will be ending. So they still have supply, but they don't know what the future is going to be. And that's very concerning for them. So there's a lot of communications going out and figuring out where everybody sits right now, and we're getting a lot of phone calls here at the HCMA. What's going on? We're talking to BMS. They're talking to their sites. They're figuring it out, and we'll notify you when we have an official statement as to what's going to happen. And we don't have that yet. And there's just kind of been a lot of interesting and different kinds of news hitting us. Like, okay, so we had the Odyssey news like 3 weeks ago. Right. And then we had the notification that Cytokinetics has been pushed back on their PDUFA date, which is when the FDA is going to be issuing a decision on the label for aficamten. That was supposed to be in September, and now it's been pushed back to December. And there was a request or communication, and I'm not going to say it was a request from, but based on the earnings call that I listened to earlier this week with Cytokinetics, the FDA has requested information on what they would like a REMS program to look like. It sounded like it was not submitted with their original submission. There's been some criticism whether they should have preemptively given a REMS program, or the question was, do we give them one or do we wait for them to ask for one? And it appears that now that the FDA would like to see one, and it's going to take them a little extra time to review that. So it's more of an administrative delay rather than anything in the data. That's the way I'm evaluating this. So Marty, you're a PI on many projects with Cytokinetics. Do you read any safety issues involved with this label, or does it sound more administrative to you?
I think this is, what we know from the phase 3 aficamten trial, Sequoia, looking at, again, aficamten, second in class myosin inhibitor in obstructive HCM. Now we're back to, again, just to be clear, on obstructive HCM. What we saw from that trial was that aficamten was very well tolerated and had a very low incident of the ejection fraction decreasing to that sort of threshold of less than 50%, which has been a little bit of an arbitrary cut point in terms of safety of these drugs, in terms of their impact on decreasing heart function. So that occurred with aficamten, but it was a very small number of patients. And those that occurred in, they didn't have any clinical consequences to that, in terms of it didn't cause an increase in symptoms, and they didn't even need to stop the drug. They just decreased, for example, the dose. So where there's no interruption in therapy there. So those are some important distinctions. So overall, then the safety profile, at least based on what we know from that trial for aficamten, looks very favorable. Okay, what is a slightly different question, which is, what will happen if aficamten were to be approved in terms of the monitoring of the use of aficamten if it's approved, is a more complicated question. And we don't know yet whether it's going to be approved. And so we don't even know whether or not there's going to be a monitoring program like what mavacamten has, a REMS program like that, or if there is, whether it could look different than what we have as well. Those are questions that are probably being looked at, kind of as we speak, by the regulatory agencies and others. And so we don't have an answer yet there.
I have never been this close to the inside of drug discovery with so many different companies and regulators nobody's been through it through these very interesting times that are challenging many people in the regulatory process.
Right.
I just got back from DC again. I was at a conference where there were members of FDA present. And I thanked them for their service and asked them for some patience while they probably are very overworked right now. There's a lot of, there are people that are changing. There are skill sets that are lost now. There are people who had been in these positions for many years doing regulatory process. You can criticize it. You can say it was a good thing, a bad thing, but you've lost some institutional knowledge and process. Right. And now you have new people who are overworked and there's processes that are going on. I would not be surprised if there are additional delays, not just with our drug space in the discovery process, but everything getting through this regulatory process with so much upheaval and so little staff and changes. So I think everybody needs to have an ounce of reality that there are people that are no longer in jobs in certain places in the FDA and within the government structure. And at some point, somebody's going to figure out that their job's not getting done and somebody's going to have to pick up that slack. So I wouldn't be surprised if we see more delays and more paperwork requests or what have you. So I just don't want it to be seen as a negative necessarily. It's just part of the process. So we have another drug trial coming up.
Well, also, I just want to mention one of the things. So, I think but just so everybody, particularly listening in terms of about this particular issue too, is that, the FDA does an incredible job for its main mission, right? Which is about safety, right? I mean, that is what this is about. Their job is to keep the patients safe, okay? And I'm just reminding everybody about that as it pertains to our disease and these drugs, because, one could sort of make the case, for example, that although this REMS program, for example, with mavacamten is complicated and burdensome and at times frustrating for patients and physicians, I think in some ways there's evidence that it has really done a good job of keeping patients safe too, which is what its main mission was.
Yes.
Okay? Right. And we kind of lose track of that because of the burden of it. But actually, it's probably done an incredibly good job of achieving the goal, which is safety.
I think they have. And having worked with them on a number of different issues now, holding a PFDD, coming to conferences about different safety issues with devices, leads, drugs, etc. It is a complex maze. It's never going to be perfect. It could always be better because every system can always be better. But at the root cause of what they do every day, their job is to keep us as safe as possible, but they cannot insulate us from everything. And nothing can. We create systems that we believe are fortified and they provide safety, and we all need that. So we just need those people to be able to do that work. And
by the way, it's it's really hard, right? I mean, when you're tasked with keeping patients safe with these very complicated drugs and diseases, these complicated drugs being used in complicated diseases, that's a huge burden, I mean, it's very, very hard. You're balancing safety and also still access and ease of use and everything else in a way that's really, really tough. And so we always have to kind of keep that in mind. These are not easy decisions.
I think it's easy to criticize systems and be critical of systems when you're outside of it. When you get in and you see the idiosyncrasies and you see the number of coordinated paths that need to be operationalized and understood and synthesized, it's amazing anything gets through it.
Yeah.
And it's a testament to what we have built in this country in a drug discovery system. And I'm afraid that we're dismantling really key parts of that system. And we as patients won't feel the impact for 3 to 5 years because that's how long these discovery processes take. And you need new drugs coming out. You need discovery evolving constantly. You can't start and stop it. It is an evolution of science and understanding. And thank God we understand as much as we do today, because look how far we've come in 25 years. You know, when I look at the CDC database on number of people who die from HCM every year, and I've been tracking this since about 2007, 2008, the number of people who die under the age of 73 or 74, I forget where the cutoff line is, from HCM, it has changed. We used to die in the highest numbers between 45 and 54. That was the highest time when our people would die. And now they're living into their 70s because we have evolved our knowledge and understanding on how to treat these patients. We're living a decade to 2 decades more just in the 25 years that we've been doing our work in this ecosystem. We've extended life. We win. We did the good thing, but now we can go further and extend life for more,
Right.
but only in an infrastructure that supports science and innovation.
Right. Right.
So I want to talk about Imbria and Edgewise real quick. And by the way, Doug just left your office and he said, hey, pop in there.
Yeah. Thanks, Doug, for the comment. I appreciate that as always.
Okay. So let's talk about Imbria and then Edgewise real quick. What's coming up in their pathways and what are your thoughts?
Well, I mean, you've got so Edgewise is a company which has another novel drug that modulates the myosin in a way that could have benefit in both obstructive and non-obstructive HCM. And so it is called Edgewise 7500 is the name of the drug right now. And it hasn't actually been named yet, but it has a number with it. And it's being investigated right now in both populations of HCM, obstructive and non-obstructive, in a phase 2 trial, which means that it's still early in investigation. So phase 2 trials, for everybody listening, we've been talking a lot about phase 3 trials up to this point. Those are the trials that if they're positive and the drugs look safe, then that drug could be approved based on a phase 3 trial because it's designed for approval at that point. Phase 2 are smaller trials in which the drug under investigation is being looked at in large part for its safety and tolerability, as well as some efficacy, but the weight is more on safety and tolerability than it is on efficacy. And so right now, what we know from kind of the phase 2 studies with this Edgewise drug is that what's been publicly released in some of the preliminary data from that is that it looks really favorable as well in terms of lowering gradients in obstructive patients that is making them feel better. How that compares to mavacamten, aficamten would be way too preliminary to say at this point. There's a lot more work that needs to be done, but so far I think the signal for efficacy is favorable in the obstructive group. We don't know as much about the non-obstructives yet, but again, it's a phase 2 study, so it's still very early in the development, but generating enthusiasm so far. And we could talk more about, we could unpack that more if you wanted to, but that's the general gist there.
So there's been some data that says there was an AFib signal in the Edgewise data. AFib is a confounding issue in most clinical trials with HCM because AFib occurs in HCM, but it's sometimes hard to know whether or not it's associated with a trial or a drug or an intervention. Can you speak anything about that or?
Yeah, I mean, it's hard because it's hard because of this confounding issue, which, so what we want to know, what we're asking here is when we're looking at a drug, for example, and in this case, it's about AFib, does the drug, is it lowering the threshold? Is it increasing the risk of an outcome like atrial fibrillation, because of some effect of the drug. Okay. And I think what you're saying is that, this is a challenging question because of the fact that AFib is an abnormal rhythm that occurs as a result of just having HCM. Okay. Right. And so it gets hard to then unpack or unpeel when we start to see atrial fibrillation occur, for example, in a clinical trial with a new drug. Is that atrial fibrillation would have occurred whether the patient was on the drug or not because they have HCM.
Right.
And so I think what we saw in the phase 2, I think what you're talking about was there was some atrial fibrillation noted in the phase 2 trial with the new Edgewise 7500. Right. I think at this point, it's just it's unclear whether or not, there's any relationship with the drug and AFib because of that issue of confounding right now. And that's part of what drug companies will have to sort out as they move forward with a larger experience with the drug in more patients with HCM, is to help clarify that question right now.
Perfect. Let's tap on Imbria for a minute and their upcoming trial design. So non-obstructive HCM, I hinted about this earlier today. And I said this last week and I'm going to say it again. I take some responsibility here. I think this isn't really about Imbria. This is about non-obstructive HCM more globally and then Imbria more specifically. I don't think our ecosystem appropriately, deeply enough understands the nuanced burdens of non-obstructive HCM with the same clarity we understand obstructive HCM. And non-obstructive moves really slow. Symptoms are harder to define. Improvement is harder to see. And we don't understand how to document all these subtle changes over a long period of time. I come from a unique perspective. I've had obstructive, non-obstructed, and a transplanted heart. Explaining symptomology and the progression of those symptoms through my non-obstructed journey is very difficult to do.
Yep.
The data dictionary, the understanding of symptom burden is so complicated to document.
Yep.
That it becomes challenging for a trial to create appropriate endpoints to truly represent the patient's journey. So You and I have talked about this many times. We know the non-obstructed population needs some more attention here. I don't have a solution. I have an observation that we have more work to do here. What are your thoughts?
Well, yeah, I mean, look, it's a much more challenging situation to show benefit than it is in obstructive, for the reasons we talked about, because obstructive HCM patients, if you have a treatment that could address the obstruction, you're going to see, no matter what, a huge benefit. Very clear. In non-obstructive, the reason why patients don't feel good or don't have as good exercise capacity is much more more complicated and also multifactorial, meaning more than one issue may be contributing in an individual patient to why they may not be feeling as good as they want on that particular day or days. And so for that reason, it makes it much more complicated of an initiative to develop therapy to make a difference here. So a couple things. One is that, we talked about the Odyssey trial with a myosin inhibitor looking like, not being positive. But just to be clear, too, is that, we also have another myosin inhibitor trial looking in the non-obstructive patients as well called Acacia HCM, which is the aficamten drug, okay? And the trial design there was a little different. It's a different drug a little bit than mavacamten. There's a number of different reasons why, we have to still have or remain optimistic that it's still possible here that we could see a benefit in non-obstructive patients with a drug like a myosin inhibitor, in this case, aficamten, okay? That story is not over at all.
No.
Right. So just so everybody listening understands how to put the discussion we had about Odyssey into context here, it's not over. okay, at all. And we'll probably know within a year or so, the results of the aficamten trial in non-obstructive patients, okay? And also good news is that, as you said, Imbria, another drug company, has developed a therapy that is being investigated in non-obstructive HCM that showed in a previous study published a couple months ago that drug called niraparib, it's kind of a complicated word to say, but
wait, say it again slower.
niraparib.
Niraparib. I have a hard time with that one.
It's a very tough one. Niraparib is the drug we're talking about. That's a compound that's been made by Imbria that has been developed for non-obstructive HCM that showed in certain group of non-obstructive patients in a preliminary study to help make them feel better and function better, okay? And so it's now, because of that, being looked at in a little bit of a bigger population of non-obstructive patients in what's called a phase 2B, which means it's still phase 2, so still kind of preliminary, but we'll have a much better idea at the end of that study what the efficacy looks like for that drug in non-obstructive patients. And if it was favorable, I think you're going to look at a bigger trial, like a phase 3 trial with that drug. And so that drug, by the way, is addressing different reasons why patients with non-obstructive HCM may be symptomatic. That's why, we've got to keep an open mind to say that the mechanism here may have a different kind of favorable effect possibly than other drugs that have been tried in non-obstructive HCM because it's a unique mechanism here, okay?
Mm-hmm.
So there's lots to consider here, for the non-obstructives in terms of efficacy, but we're going to learn a lot more here with these drugs within the next year or so, okay?
In 2025, in May, middle of the year, all the things happening around us, how much better off are patients with HCM with their medical management options than they were when we started this game 25 years ago?
I mean, it's not even close. I mean, I think, you alluded to this already, and we've also looked at this too, is just that if you look at mortality as a barometer of the impact of all of the advancements in treatment in this disease over the last half century, the impact that they have made in making patients feel better, but also live longer is just indisputable at this point, okay? And we have more room to go, of course, but there's just no question that it is a different deal with HCM today in terms of outlook than it was 10, 20, 30 years ago.
There's a couple of questions out here I want to address, and I also want to comment on where I just came from this week. For those who follow me on social media, you might have noticed I was back in Washington, D.C. I was participating in a symposium from an organization that we are really excited to become a partner with, and that is the National Health Council, which is the largest patient organization. They represent the largest organizations in patient advocacy in the United States. So they're an amazing organization who do amazing things across multiple disease states and patient advocacy efforts. And I was there learning about the implementation of artificial intelligence and machine learning and new technologies in the future of patient advocacy and data collection.
Yep.
Geeky issue. So I was so happy. Guys, I really feel like I need a hobby in life because I'm like geeking out on AI now at a deep level. So Curtis, who's posting a question, asked a really great question that I've been wondering the answer to for 25, 30 years. And Marty, I've talked about this a lot. What is the impact on menopause, perimenopause to women with hypertrophic cardiomyopathy? And we don't know the answer. So why am I telling you where I was and bringing up this question? I think the answer and the ability for us to identify whether there is a correlation between menopause and disease progression, the answer may lie in AI and our medical records and an ability to start digging in and asking questions differently of women with HCM. And we have some really exciting potential partners who can help us build some algorithms that can help us evaluate this population and other subpopulations. So I think it's a great story or a great research area. And I'm going to, so she puts the first question, do symptoms of HCM worsen during perimenopause? For some people, yes, they do. Is there a connection between perimenopause or is it another factor? I don't know. We're going to figure that out. But your follow-up comment, I believe that my heart thickened the ventricle, actually might do the opposite for some people. It may cause the heart to thin and get a little weaker or stiffer rather than thicken up during changes of hormones. We're seeing some signals of that, but I don't know that it's true. So we have to look at patients in a deeper way. So in a few weeks, you're going to be getting some notifications about the HCMA patient registry and your ability to consent. Yep. We're going to be looking at new ways to integrate your electronic medical record. So you don't have to do a lot. You just have to consent. And we're going to use things like machine learning and artificial intelligence to really dig deeply into certain questions to see if maybe the computers are smarter than the people or our observations as people are smarter. So you're going to have an opportunity to help us answer some of these questions. And I encourage you to get involved. We may have focus groups on this. Please participate. Please get involved in patient research at a deeper level. Your history, your lived experience can be a teacher to so many. And if we collect that information in an organized way, we can actually change our understanding and maybe meet your needs a little bit more directly. So AI, these silly little things we wear, how do we really amplify their use to improve our quality of life, not just sell us shit? So what do you think, Marty?
Yeah.
Where are we going with AI?
Yep. Well, I think, it's hard to know for sure where we're ultimately going with AI.
Don't know.
Yeah, I mean, to presume that I know, or maybe anybody knows at this point, would probably be a mistake. Here's what I would say. I think I have little question in my mind that AI is going to play in certain ways, for sure, a very important role in how we take care of patients with this disease in the future. Okay. The extent of that and exactly how that will look like, I think, is harder to describe. I'll give one example. I think that, for example, the ability to apply that technology, artificial intelligence, to, for example, interpreting the EKG, the electrocardiogram, in a way that we can't interpret it right as humans with our eyes, and meaning that it can tell us something about the pattern with the EKG, the AI, that we can't discern with our own eyes. And that's an example where, there could be a very clear impact of AI, on that test that could translate into, for example, patients being identified, diagnosed earlier with HCM because of that. And so that's just one example of the potential impact here. Where it will end up at the end of the day down the road in terms of the extent, tough to say.
We don't know, but we know that healthcare is changing. Technology is changing. Our expectations as patients are changing. They need to converge, and we need to get some harmony as to where we're all going together, because it's been a little frantic. It's been a little anti-science-y. We need to bring people back to science, and I think we'll all do better as society. Just wanted to end this podcast with the acknowledgement to my Catholic grandmother that we have an American Pope. Kate Flanagan's probably smiling up there right now going, yay, we have an American Pope. And I know a lot of Americans are excited about that. And from my Irish Catholic and Slavic Catholic background, yay, American Pope. And we also found that we lost a former Supreme Court Justice, Justice Souter. So we have some epic things going on in the universe right now, and I'm hoping that we come to some calm in the world where we can actually start making the progress that we need to make. Marty, thank you for joining us on Tales from the Heart, and thanks to all of you who are participating with your comments throughout the event. We had people from Italy, from the United States, from all over the place. So thanks everybody for listening, and we'll catch you next time on Tales from the Heart.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.